am Robert McMullen, MD. I'm a psychiatrist in New York City, and I've been practicing over 30 years, specializing in medication and in TMS, which is transcranial magnetic stimulation, which I've been doing the last 7 years. I went to Georgetown Medical School, which is a great place, and to my residency at Columbia Presbyterian. Now, the question I was just asked is, how do you find a good psychiatrist? And that is a problem, you know. That's a difficult thing, because if you have a friend who did really well with somebody, you think, well, they may be really good, but it might have been a very simple thing. He had a very simple depression, took some Prozac or Zoloft, and got better easily, but maybe he's not the greatest psychiatrist. How do you know? When my mother had a orthopedic problem, I believe it was a broken hip, and she was in some other state, the way I did it was I called the local teaching hospital and asked to speak to the chief resident in orthopedics. And I said, off the record, could you please suggest to me who would be a really good orthopedist for my mother? Or in other circumstances, I've asked, this person is going to see so-and-so, what do you think? And then if they recommend somebody, you can be pretty sure that that person is good, because this is a person who's in training there, and this is one of his teachers, and he picked out that teacher rather than 9 or 10 other people he could have picked out. So then you're fairly good. That's one way to do it. Another way is to look on the internet, and there's all of these websites that rate doctors, and I think that's a reasonable place to look. Another thing is if you find out that a doctor is particularly good, or a lot of people think he's good, you can call him up and ask him, I have a patient that doesn't want to see a male, he wants to see a female. Do you have a woman psychiatrist that you could recommend? And then you can kind of assume that if he's really that good, he'll recommend somebody who's good. And vice versa, if you could call up a woman psychiatrist and ask for a male. Now, it may be that you don't care whether it's a male or a female, but you don't want to you want a reason for them to recommend somebody else other than themselves. So that's a good way to get around it. It's a difficult problem. I had a acquaintance once, he's deceased now, and he was a surgeon at a small hospital. And everybody that worked with him, the other surgeons, everybody said he was the most fantastic surgeon. He could do anything, and he could do it very fast and really well. His patients almost always did well, and he trained at a good place. But he's at a small to medium-sized hospital. It's not a teaching hospital. So I would say, based on everybody who knew him, that he probably was one of the best surgeons in all of New York. But who would know that? The only people that knew that are people that were in the hospital and who the anesthesiologist and the other surgeons who actually did work with him. And so that's why it's hard to find a good doctor sometimes. And you want a psychiatrist who's flexible, somebody who keeps up on the literature and who's willing to try different things and is willing to look at new things. Even the patients bring in things and they say, what about this? And sometimes the things patients have brought into me turned out to be very important, and I didn't know about them. One patient brought in this information about syncope, about spontaneous syncope being related to orthostatic hypotension and causing people to be chronically fatigued. And I had never heard of this, and I looked it up and found out about it, and it turned out in this woman it made a big difference. When I gave her medicine to keep her blood pressure up, her energy got better. And in subsequent years, I ran across 3 or 4 other women with exactly the same problem. And there's a lot of things out there that a particular doctor might not know of. One thing that also you should think about, if you're seeing a doctor or a psychiatrist for some time and you're not improving a lot, then you should think about a second opinion. And it's often the fact, well, I'll give you one example. Frequently, those of us with chronic depression are a little bipolar. It doesn't mean manic depressive, but just that our moods can swing a little and cycle. And at times, maybe we could be very enthusiastic and have a lot of energy. Maybe it hasn't happened in 30 years, but we could in the past. And that means there's a little bit of bipolarity in the person. And in those people, often the antidepressants aren't working. They work, or they work for a while, and then they poop out, and the person's doing terrible even on all these medicines. Now, if you're doing terrible on a lot of antidepressants for a few years, then you shouldn't be on them. I just heard a lecture by Gary Sachs, who's the head of the bipolar clinic at Harvard, and he said, well, some of the wisdom we have that we want to pass on from Harvard is that if something's not working, stop it. And if something is working, keep on using it. And it's something that a lot of people don't think about. They keep people on antidepressants for years, even though the person is doing terrible. And when you first come down off an antidepressant like that, you might get a little bit more depressed for a while, but it may not last, and you may not ultimately get any worse than you are. You may need to be on a completely different antidepressant or on a combination of things.
So how you know that the doctor, the psychiatrist is really for you and you match him? It's a good match.
Well, it's really hard to know, because you might really like the person and you might get along with them very well personally, but maybe they're not making the best decisions. You know, it's really hard to know. I think what would make me feel more comfortable is if the doctor seems very open-minded and he's always thinking about things and he's concentrating on what you're telling him and the symptoms, and he's thinking of different alternatives. And if you're not at 100%, he's thinking about, should we add a little cytomel? Should we add a tiny amount of lithium? Should we add, there's various nutritional things you can add, like probiotics and NAC, N-acetylcysteine. Is he thinking about these things, and then saying, well, you know, actually this antidepressant is only working 50%. It's not really working that great. Maybe we should add a completely different type of antidepressant and use 2 together. There was a famous cardiologist whose name was Ziegler, and he was talking about high blood pressure, and he says, there's no super drug for high blood pressure. He says the best treatment for high blood pressure is low doses of 2 or 3 or even more blood pressure medications. And that struck me, because it's similar in psychiatry. There's no super drug for depression. Unless the first one you try, if it works 100% and you're really great, then that's fine. But if you have a hard time finding something that brings you all the way to 100%, then you're better off on 2 or 3 things in lower doses, because you'll get low side effects and you'll get more efficacy because you're using different things. You know, you're coming at the problem from different angles, so you're more likely to get benefit. And if somebody's a little bit more on the bipolar side where they're swinging, and I don't mean that they're necessarily having highs that are very noticeable, but they're just fluctuating between retarded depression and agitated depression, or they're cycling in some way. Those people, we found, need even more, and more medicines. Dr. Carpenter, I think he's a specialist in schizophrenia. I heard him say once that why are all these bipolar people on so much medicine? They're on 6 medicines, 7 medicines, even more. Why are they taking so much medicine? And then I've got a couple of other people and they just take some Balta or Prozac or something and that's all they need. He says the reason they're taking so much medication is because they need it. For some reason, bipolar disorder is like complicated blood pressure. A simple single medicine is not going to do it. Even with blood pressure, if you have a case that's hard to get better, sometimes 6 months later, the person's on 5 different medicines for their blood pressure. And the brain is a lot more complicated than the heart. So it's not surprising that some people need a lot more medicine. But usually you should go after the medicines methodically. Add one thing. If it doesn't seem to help at all, you stop it.
How much time you need to wait between
changing? Usually you should wait 4 weeks or 6 weeks. Now, that can be a problem because if you're going to try one thing and then wait 6 weeks, and then another thing and then wait 6 weeks, and you're going to have to do 5 things, that's 30 weeks. And if it's an emergency and somebody's going to lose their job and their wife is going to leave them and there's all sorts of catastrophic things going on, you don't really have the luxury to do that. So in that case, I might go with one thing that I might think of as the main medicines. For example, Cymbalta, duloxetine. But there's many different antidepressants. And then, at the same time, add a very low dose of lithium, 150. Add a very low dose of cytomel, 25 micrograms. Add fish oil. Add NAC. Add a probiotic. And the fish oil, the NAC, and the probiotic are really nutritional things that are completely benign. And the low doses of lithium and cytomel are almost always without side effects, and they're not going to hurt. And there's evidence that these things work. So sometimes doing a few things at once is okay, especially if some of them there's really no downside. And then when the person gets better, then you can sort it out.
So if a person not getting better after, like, say, how long time you need to wait to get a second opinion?
Well, if you've been working on it for 6 months and things really haven't improved much at all, then I'd definitely get a second opinion, for sure. I'm thinking, I had one patient who I treated 11 years, and she was chronically, mildly depressed, and then every year or two she'd go into this really big depression. And when she was working, she had a special type of profession where when she was, getting ready for a production or in the middle of it, then her mood would be pretty good. She'd be really bubbly and on top of things. But the rest of the time she was chronically depressed. And then one time she had this really severe depression about 8 years ago, where she could barely walk or talk. And she was already on 2 or 3 medications. It was really hard for me to know what to do. So I sat down and I thought about it, and I decided to do 3 things. I added Abilify, 2 milligrams. It's a low dose of an atypical antipsychotic that can help depression. I think it's FDA approved for it, in fact. And cytomel 25, it's a type of thyroid hormone. And lithium 300, a relatively low dose of medicine. And these were relatively benign things to add that I didn't expect them to cause a lot of side effects, and if she got better, we could sort it out later. Now, in about a week, she was almost completely better. It was really quite surprising. Now, in retrospect, she and I think it was probably mainly the lithium, but it's hard to tell. But anyway, she got almost totally better, and then as the months went by, I started taking things away. And then she said, you know, Dr. McMullen, this was a year ago, she says, I think the best medicine you ever gave me was that little lithium pill, the 150 of lithium. And I said, well, how's that? And she went over this whole story, and it turns out that all she's taking now is Lamictal 200, lithium 150, and I believe she's on the cytomel. And she's been completely normal for 7 years. No big depressions in 7 years. Plus, the rest of the time, when I look back on my notes, she always came in, she was fine. She was euthymic almost 95% of the time. And cheerful and completely different than the previous 11 years. Now, the only thing that changed, really, is the lithium. Now, originally, I'd put her on 300, but after, sometime later, I reduced it to 150. And she was always on Lamictal. So now she's on much less medicine than she was previously, and the only real change is the lithium. I've had 44 people who had a really good response to adding 150 of lithium to whatever they're on. But I tried this on a few hundred people, so it's not like it happens all the time. And but things like that, there's some things like that that have that are very safe, but have a fairly good chance of helping. But in her case, I couldn't wait around and try one thing for 6 weeks and then another thing for 6 weeks. I had to go and add a few things at once, and later on, we sorted it out and took away things and found out what she basically needed.
Thank you very much, Doctor.